I prefer this way, it's very easy. Just screw 2 turns only of the mini screw and then take the x-ray. When you screw it in, when taking x-ray, you check. Now you will not penetrate the tooth, the root, and also you can check the way of the insertion way of the mini screw. Measuring the thickness of the soft tissue. When we fix it in the palate, as you see here, we have to know the thickness of the palate, just to choose the length of the mini screw. So we have two ways. We can just make anesthesia, put anesthesia here in this area and start the area, and then you can use the stopper of the endo stopper on the left side and take the measurement and try to put the screw longer than this. Try to use the longest one if it's long, if it's thick, I mean. Depends on the thing you want. This is the movie, you can see it for insertion. Here's how after anesthesia you can put marks like this on the gum, on the gingiva, like this. Follow up the root of the right and left tooth. Here's the first drilling. Put always normal saline, low speed. Blood's coming. Here the screw will come. You have always to keep irrigating. لازم دائما نحط إرقاء أو normal saline. Screw it slowly, not to create any heat. Irrigation always. Screw it in now. This is one of the kinds. There are too many kinds of mini screws and the ways now. We have also with the like mini implants or micro implants and mini screws with the hydroxyl apatite, without. Now we can put the bottom. Here's the bottom, fixing the bottom now. They try always to make it parallel to the occlusal surface or to occlusal plane, and that's it. Hammer it. That's all. We have to start first of all with the scrubbing the area. Here are some applications of the mini screws. We can use the elastomeric thread to intrude it, extrude, whatever you want. You can do many things, whatever you want. It's our dream in orthodontics. We can do many things we were dreaming in. Here's extraction, retraction, intrusion. You can put it also in the, as we see here, in the frenum area. You can get it through under the gum. Put the thread underneath, it will not be visible, and you can create intrusion also. Retraction, distalization of the lower teeth. Here also a brightening, intrusion, as you see. Here, how do you see here in the tuberosity area. Tuberosity area here. Also on the lower teeth. Intrude, extrude. Here also this one I think is good for the prosthodontist. Not to depend on the orthodontist. In some of the areas, extruded teeth to edentulous area, so you can use this way. Just put an orthodontic wire in between the teeth. You can connect them together. Put some composite on both. One screw from inside, one screw from outside, and you can intrude the teeth. You can intrude all the teeth all together. Okay, a brightening here. all the way. You can distalize with retract with on the upper area above the center of resistance to get some retraction with rotation. Here we can see the biomechanics. There are three levels actually they are following up. On the upper we have 8 to 10 millimeters. In the medium level, high level is more than 10, low level is less than 8. And on the lower we have low, medium and high. Between 6 and 8 is medium, between 8 and more than 8 is high, less than 6 is low. On the mandible we can see here, while fixing the braces we can get on the lower way, you can create now on the lower we can create clockwise rotation of the posterior and counterclockwise rotation of the anterior. So it depends on the case. On the lower two, if it's higher, it's in a high position, you can create counterclockwise rotation of the posterior and anterior. Here also you can see it. While retracting, we need to close the bite at the same time. Here also, less than on the low level, we can see here counterclockwise rotation of both two. On the maxilla, the same, high level, counterclockwise. It depends on the treatment we needed. With the high angle, with the open bite, also only retraction depends. So you have to know what you need. You have to know where you have to fix the mini screw and to retract. The drilling speed should be 300 to 500, and always with should be irrigated. The area should be irrigated as we saw with the normal saline, and this just to reduce the heat and to lubricate the area. If we don't do it, if we create any heat at the area, we'll get osseous necrosis. Immediate loading versus delayed. So they found that there's no difference. In the past, they used to keep the mini screws 4 to 6 months for healing and for osseointegration, and so nowadays it's not important just to do that. As Lom and colleagues, they compared the hydroxyl apatite coated to uncoated plate types implants in rhesus monkeys. They found that they are both the same delay or direct loading. They didn't see any fibrous tissue invasion. Here are some cases. This is the case: 15-year-old male, class 1 skeletally, class 2 dentally, convex profile. The treatment plan was to extract for force extraction. Here we put the TPA and lingual arch on the lower. First of all, the first alignment, when they start with the first alignment, they do it, and then when they fixed the mini screw, they started retracting the upper and the lower. They removed for sure the lingual arch and retract the teeth. Here's the idea during this progress. Here we can see the place of the mini screw in between. And here's the result down. Next case is 13-year-old male, class 3 dentally, class 1 skeletal open bite, high angle, long face, incompetent lips. Here's how they start with the expansion. Lingual arch on the lower, start alignment TPA, upper to maintain the transverse width. Here they start with the anterior box, anterior elastics, and they use the elastic here. They use the elastics on the mini screw here in this area to extrude all, to make a rotation for the maxilla. As he is the 13 years old. Here's the result. For lingual orthodontics also, we did one case, Dr. Hussam, I think, with Dr. Nauras. We tried to, I don't know what happened with that case. Going now? Finished almost. So we can use this case. Here's lingual orthodontics. We can use it for anchorage. As you put it here in this area to retract the teeth. This is my case. This is Zuhur. She's 28 years old, female. She's class 2 dentally, class 2 div 1 dental and skeletal class 2. She's an eye angle case, gummy smile, convex profile, constricted maxilla. This is before. These are the panoramic X-ray and the CEF. I tried to take the last CEF, but she didn't come. The patient. Here's the progress. Here's what she's now. You can see here the maxilla is expanded. We use the quad helix to expand, and at the same time we use the mini screws, because we know when you use the TPA, as she's shallow bite, she has a shallow bite, we'll get some extrude, some open bite in the anterior. So we prefer just to put mini screws and at the same time the quad helix. So right now she's like this. You can see the difference now between here's the profile before and during now. Here's before the protrusion. Here's right now, and here's the buccal corridors also. We don't see buccal corridors right now due to the expansion. Here's also the class 2 canine on the right side. Class 2 canine. It's about to be class 1. We start now to remove the TPA, the quad helix, to make it easy to retract the teeth. Thanks from the heart to everyone. Thank you very much.